Dear participant, my name is Mariangela Pellegrini. I'm the project manager for the European Reference Network on Rare Hematological Disease, EuroBloodNet. And it's my great pleasure to welcome you on behalf of the whole ERN to this session of the Thursday webinars. As you may know, the aim of this educational activity is promoting the interest on very innovative topics, with the aim to stress and disseminate among health professionals the cutting-edge advances in the field of rare hematological disease. And today we are going to assist to a lecture on CNS and ocular lymphoma. So, dear audience, please welcome with me the two speakers of today. So, the Dr. Carole Soussain and Dr. Denis Malaise. For introducing them to you, Dr. Soussain is a physician specializing in clinical hematology with the experience in the field of malignant hematological disorder like lymphoma, myeloma, leukemia, with a special focus on CNS lymphoma. And she's involved in several clinical and translational research projects as part of various collaborative academic groups aimed at improving the understanding and treatment of CNS and intraocular lymphoma. And she's also the hematology coordinator for the National Reference Center for Primary CNS Lymphoma, and she's responsible for primary CNS lymphoma within the ERN-EuroBloodNet network. And with her, we have also said Dr. Denis Malaise, who collaborates with her on this topic, and he's ophthalmologist at the Institut Curie in France, in Paris, in the service of onco-ophthalmology for lymphoid malignancies. So please, the floor is to you. Thank you very much.
Thank you for the introduction and for the invitation, and thank you to those who attend this webinar. We chose to focus our talk today on primary VitreoRetina Lymphoma. We're not going to talk about CNS lymphoma because it would be too long. It's just half an hour, and there is a lot to say on primary VitreoRetina Lymphoma about the diagnostic and management challenges. So I do have grants for preclinical research as conflict of interest. So the objective of this webinar is to optimize the knowledge about the diagnostic procedure, give you a review of the literature of therapeutic options and results, and identify the next challenges to be addressed in this disease. So some generalities to start with. The primary VitreoRetina lymphoma is a high-grade extranodal non-Hodgkin lymphoma that affects the vitreous, the retina, or exceptionally the optic nerve, but there is no brain infiltration and no systemic involvement by the lymphoma. The PVRL is a subgroup of primary CNS lymphoma, and it has been identified in the WHO classification in 2006. And in most of the cases, it's the infiltration is made by diffuse large B-cell lymphoma cells. It's a rare disease. To give an estimated incidence of the disease, there is about approximately 50 new cases per year in US, and in France we have about 10 new cases per year in France, as far as we can know from our national database. There is probably a little bit more, but not a lot more than that. There is a slight female predominance, and it's specific by its localization, because it's in the eye, which is normally not in where there is no lymphocytes. There is a very specific blood retina barrier, which limits the biodisponibility of the drugs in the intraocular compartment. It's very similar to the blood-brain barrier. It's made of tight junctions between endothelial cells, and there is an extra layer of cells that make the barrier more impermeable. And also the microenvironment is very specific because there is an immune tolerance of the brain, but also of the eye microenvironment. So I'll give the screen to Denis to talk to you about the ophthalmologic signs.
Yes, I take the control of the screen. Do you hear me?
Yes.
Okay, perfect. So about the symptoms of PVRL, indeed, PVRL is also called a masquerade syndrome. It means that the onset of the pathology is quite insidious. One of the main symptoms of the patient is floaters or just blurred vision. Indeed, floaters or blurred vision are completely aspecific of, and it's frequently seen in many ophthalmological diseases. So another problem with PVRL is the fact that the initial symptoms can respond to steroids used for other pathology. So the diagnosis of PVRL is not evoked quite soon. Indeed, PVRL is what we can call a uveitis-like disease, mimicking uveitis in the anterior, the intermediate, or the posterior part of the eye. And resulting of that aspect of masquerade syndrome, there is a delay of diagnosis of about 40 months since the first symptoms of floaters or blurred vision and the final diagnosis of PVRL. It's completely different, for example, as in case of PCNSL, where diagnosis is made in an interval of time of 35 days. The diagnosis is evoked with ophthalmological examination. Indeed, just to focus on the right pathology, here is a schema of the eye. And today we discuss about PVRL, which is a lymphoma in the vitreous part of the eye, so the interior of the eye, and the retina, one of the three parts of one of the three layers of the eye. So we do not discuss about uveal lymphoma, which can arise in the iris, the ciliary body, or the choroid, which are mainly secondary disease from a systemic high-grade lymphoma. So just to be sure, we discuss about the good pathology, we discuss about PVRL, so the vitreous and the retina here. Well, when we examine a patient, the first test we perform is a slit lamp examination. You all know that this machine, and with this we can focus on the anterior part of the eye where we can see just few keratic precipitates, is clump of inflammatory cells close to the cornea, and we can see there a gray and another gray is called cellular gray diffuse keratic precipitates. A second, and it's the most frequent one, sign of PVRL is clump of lymphoma cells in the anterior vitreous, located here, just in the anterior part of the vitreous. We can see a type of a spider web with just small clump of lymphoma cells there. The second examination we perform is an examination of the fundus, so the vitreous body and the retina. The first thing we can see is vitritis. It means that the vitreous is not clear, it's blurred, and we cannot clearly see the detail of the retina on that right eye. At the opposite, on the left eye, the vitreous is clear, so we can see the detail of the retina, but we can see here multifocal cream-colored retinal spots. There are small ones in all of that part of the retina, and it's lymphoma cells just in and beyond the retina. Another aspect of larger lesions that appear in nearly more than the half of the retina. We also have other type of examination to to evoke lymphoma, primary vitreoretinal lymphoma. The first one is fluorescein angiography, where we inject to the patient a contrast agent, and after we can see vessels, but also the retina, and there are different aspects of hyperfluorescence lesion, white one, and hypofluorescent lesion, the black one. And with PVRL, which is characteristic, is the alternance of white and black spots, and black spots are the lymphoma cells into the retina, and the white spots are scars of in the retina, and in fact the scars are thinner than the normal retina, and we can see the fluorescence from the underlying tissue. So it's a characteristic aspect of lymphoma, the alternance of hyperfluorescence and hypofluorescence on the retina. But angiography is invasive, and we can also use OCT, which is a non-invasive procedure where we can see the different layers of the retina. On the left part of the picture, it's just a picture of the retina with the cream-colored infiltrate into the retina. It's indeed lymphoma cells, and we perform an image of the different layers of the retina here in this position of the line, and we can see under the retina, which is here, we can see under where there is the star, subretinal deposits of lymphoma cells. It's really characteristic because we can locate it here between the epithelium pigmentary system and the Bruch membrane. It's quite pathognomonic. When we think about PVRL, we have to prove it. The first thing we can do is an anterior chamber tap. Indeed, we can collect aqueous humor here in the anterior part of the eye, so between the cornea and the iris. Just under topical anesthesia, in 2 minutes, in an operating room, we can collect a few microliters of aqueous humor, and with aqueous humor, we can evaluate interleukin dosage, and we focus on IL-10 and IL-6 and a ratio between them. And with a mathematical formula, we can calculate a predictive score of vitreoretinal lymphoma. And indeed, anterior chamber tap is also important for differential diagnosis because, as I said before, PVRL is quite, as the same person could have the same initial presentation as uveitis. So we can exclude inflammatory or infectious disease on anterior chamber tap. But the good diagnosis is to made using a diagnostic vitrectomy. So we will collect vitreous inside the eye, and of course it's an operation under local or general anesthesia. On vitreous, we can perform cytology, which is a gold standard for diagnosis, but many other tests can also be performed as immunohistochemistry, flow cytometry, or PCR to observe the CD20 positive B cells, or monotypic light chain expression. Molecular biology could also be performed, and also an evaluation of the different interleukin in the vitreous, mainly IL-10 and IL-6. In some cases, when diagnosis is difficult, we can also perform a biopsy directly into the retina, and it's the eye before and the eye after, and of course also after treatment. But here we can see the scar of the retinal biopsy performed. So in one of the 3 layers of the wall of the eye. So in summary, for the diagnosis part, we have just ophthalmological examination, typical slit lamp, fundus examination, and also invasive test angiography and non-invasive test OCT. And when we have a suspicion of PVRL, we take eye samples from aqueous humor located here, but mainly vitreous and sometimes retina to perform cytology, immunohistochemistry, cytokines evaluation, and molecular biology. Oops. And Carole, it's for you.
Yes, I just need to, sorry. I thought I was, yes. So
That's
then
fine.
Can you see my screen?
Yes.
Okay. So once the diagnosis of intraocular lymphoma is made, we need to, in order to make the diagnosis of primary vitreoretinal lymphoma, to rule out a brain and extra CNS lymphoma involvement. So it is very important to do a complete workup. with a cerebral MRI, because we can have CNS lymphoma with intraocular involvement, CSF examination with at least cytology and flow cytometry to exclude CSF infiltration, but also either a body CT scan or a body TEP scan, and some teams recommend bone marrow biopsy. And indeed, for example, in this case of a patient, this patient presented with ophthalmologic symptoms. He had an intraocular lymphoma, but also lymphoma cells in the CSF. And at the TEP, we saw nodal, spleen, and involvement. So this patient had a stage 4 DLBCL lymphoma. And the treatment is completely different, of course, so it is very important. Regarding the therapeutic issues, what are the objectives of the treatment? So what we didn't say at the beginning is that the primary intraocular lymphoma can present as an indolent disease with only floaters or blood vision, but it is a very aggressive disease. Patient can lose their vision. So first objective of the treatment is to restore the patient's vision, but also to decrease the incidence of CNS relapses. And these CNS relapses occur almost always in the history of the primary VitreoRetina lymphoma. And some studies said that CNS relapse occur between 56 or 90% of cases within 30 months of diagnosis. So what are the options? First, there are local treatments that can be delivered either with intravitreal chemotherapy or ocular radiotherapy. What do we know about the chemotherapy in the eye? The main drugs used are methotrexate and rituximab, a little bit of melphalan, but it's usually methotrexate and rituximab that can be administered in the vitreous. The advantages of this intravitreal chemotherapy are a rapid action of the chemotherapy, and it's a safe procedure, but it doesn't prevent the CNS relapse. Also, we can irradiate the eyes with external beam ocular radiotherapy. As other DLBCL, the lymphoma cells are sensitive to the radiation, but it's very difficult to cure with only radiation. Historically, 35 to 45 grays were delivered with a high rate of complication, especially radiation retinopathy. Irradiation is rarely used as sole treatment. The advantage is that if you decrease the dose under 30 grays, it's a safe procedure with a less incidence of radiation retinopathy, but still some radiation retinopathy as they are described with lower dose. And it can be useful for bilateral primary VitreoRetina lymphoma to decrease the number of intravitreous IVT chemotherapy injection. But also, like the other local treatment, it doesn't prevent CNS relapse. So the other option are the systemic treatments with the objective to again restore, clear the eye, but also decrease the CNS relapse. And usually the systemic treatment used in VitreoRetina lymphoma are PCNS-like treatment that are used for CNS lymphoma, and based on high-dose methotrexate combined with a number of other drugs with no consensus of the combination, but the main drug being high-dose methotrexate given in the induction treatment phase, followed by consolidation treatment with whole brain irradiation associated or not with a local eye ophthalmologic treatment. So because it's a very rare disease, in the literature, there are numerous studies, a lot of studies, but including only few cases. So it's very difficult to draw conclusion of the best treatment. There are mainly retrospective studies with heterogeneous treatment and heterogeneous method of assessment of the therapeutic response. So what do these studies give as do they give a good signal about the efficacy of systemic treatment? I would say it's orange light, and we'll see more details. Here is a slide to show you the number of studies, showing that they are mainly retrospective. There are two bigger studies, but they are very heterogeneous. And the prospective study included very low number of patients, only 10 or 11. And then if you look at the type of treatment, it is very heterogeneous among the studies. It can be IV chemotherapy associated or not with the local treatment. The local treatment can be either intravitreous chemotherapy or irradiation, and sometimes there is also a brain irradiation. And if we look at the survival, the median PFS is between 18 and 29 months, with a longer median overall survival ranging from 58 to 75 months. And if we look at the CNS events to see if the systemic treatment decrease the incidence of CNS relapse, for some studies there is no difference between systemic and no systemic treatment, but the more recent studies and also the two prospective cohort studies seem to show a difference with the decreased incidence of CNS relapse when the patients receive systemic treatment, systemic PCNS like chemotherapy. So in summary, the treatment option are either local treatment, intravitreal chemotherapy or ocular radiotherapy that can be efficient on the locally, and systemic treatment that is also that can also clear the intraocular lymphoma and maybe decrease the incidence on CNS relapse. There are also other therapeutic options. We can talk about, especially in relapse patients, of consolidation with intensive chemotherapy and autologous stem cell transplantation. There are a number of series, mainly from the French groups. And in summary, I won't show you all the studies, but the 5-year PFS is approximately 50% for relapse patients. There are also a number of single agent chemotherapy that showed efficacy in intraocular lymphoma. Temozolomide in a retrospective study gave a CR rate of 70% with a median PFS of 11 months. And two target therapy, ibrutinib, that was assessed in a prospective phase 2 study, including CNS and intraocular lymphoma patients in relapse. And for patients with intraocular lymphoma, there were 12 patients in relapse, including in this study. CR was 71%, and the median PFS was 23 months. We had a very nice efficacy of ibrutinib in the eye. The other target drug was lenalidomide plus rituximab, and again, this was in the prospective phase 2 study. 17 patients with PVR were included. CR was 35% with a median PFS of 9 months. I'll present you briefly the experience of the French group. Because we have a national database for CNS lymphoma and intraocular lymphoma. And from January 2011 and March 2018, more than 1,500 PCNSL patients were registered, and among them, 69 patients had a primary VitreoRetina lymphoma, and 64 received a systemic chemotherapy. And within these 64, 59 received high-dose methotrexate. The treatment was associated with a local treatment in 8 patients. So we looked at the outcome of these patients who received a systemic high-dose methotrexate. It was published recently. Median age was 70 years old. Patients received methotrexate mainly with a dose of 3 grams or above per meter square of methotrexate in different kind of combinations. And the outcome after the induction treatment, 70% were considered in CR, 5% in partial remission, 23% had progressive disease. 42 patients relapsed, and the relapse occurred either as isolated intraocular relapse in a third of the patients, or as a CNS or intraocular relapse. Systemic relapse were exceptional, only 1%, and isolated CNS relapse in 12%. And finally, as the usual natural history of primary VitreoRetina lymphoma, the cause of death, 20 patients died, and the cause of death was mainly the lymphoma brain relapse. These are the survival curve, and what we observed is that the PFS was 18 months, but the brain-free survival was pretty good, 73%, as the overall survival of 75%. Just now, let's see the challenges of the primary VitreoRetina lymphoma. There are various. It's challenging at diagnosis, challenging at treatment, and challenging for the response assessment. So for the diagnosis, when the lymphoma cells in the vitreous are very sensitive, very fragile. And the sensibility of the cytology, which is the gold standard for diagnosis, is low, only 45, 60%. And this is an illustration in the vitreous that there are many reactive cells and very rare lymphoma cells within cellular debris. This is an illustration of very nice picture. This is one lymphoma cells and reactive cells. So to optimize the vitrectomy, there are, let's say, 3 rules. Steroids must be discontinued several weeks before vitrectomy. And the ophthalmologist and the cytologist or the pathologist really need to work together, and they need to be trained in handling vitreous samples because the vitreous need to be analyzed immediately after the vitrectomy. And the vitreous need to be analyzed pure and also diluted. So there are some rules. Here is the table where we summarize the technique to optimize the vitrectomy. We won't enter the details, but there is some rules, and the vitrectomy cannot just be sent to the lab and analyzed a day or 2 after, or that would mean useless vitrectomy. And the diagnostic procedure also is very heterogeneous. We conducted within the EuroBloodNet a European survey to know more about the practice in the real life. And we see that even among specialists, people don't use the same diagnostic procedures. For example, OCT is not very well known by hematologists. They are more used by ophthalmologists. Or the molecular biology, or even the cytokine are not used by all the specialists and in all countries. Then the treatment, I show you the literature. It's very difficult to know what treatment, which treatment is better than the other one. And again, it's very heterogeneous. And in the European treatment, we can see that there is no standard of care, and everybody do either local or systemic treatment or even both, and we couldn't identify a pattern of treatment within ophthalmologists or hematologists. The response assessment is also very challenging. Why? The primary vitreous lymphoma is the response assessment is based on a clinical evaluation only. So it's not like we don't trust our ophthalmologists because we really trust in their examination, but it's the only lymphoma for which the clinical evaluation is not completed by imaging or biomarkers. And it's therefore a very subjective definition of CR, PR, and relapse, because there is no real mass, and the definition of true complete remission is very difficult. We don't have the equivalent of the PET scan for DLBCL, systemic DLBCL. It's very heterogeneous among, as we observed in the European study, especially the angiography is not known to be useful in the response assessment by hematologists as neuro-oncologists, as the OCT. The cytokine are not very used also, or not very known as a response assessment for hematologists and ophthalmologists. So how to improve that? We really need to homogenize the diagnostic procedure, and maybe you'll have questions about that, but we need to use the same procedure with cytokine, OCT, angiography if necessary. We really need to better define the therapeutic response to identify the true CR, the partial remissions, especially. The progression are easier to define, but complete remission and partial remission are more tricky. And we really need to design collaborative prospective studies in order to identify the best treatment option. So for example, we, in our group, the French LOC network, we define our guidelines for primary VitreoRetina lymphoma based on the literature and based also on the experience, and I show you the results of our experience. So we usually choose PCNSL-like chemotherapy based on high-dose methotrexate for patients with good general condition and good renal function. And because we had a lot of relapse in the eyes in the study that I previously showed, we now recommend to consolidate patients in CR or PR with a local treatment with low dose irradiation. And then we'll see, because we homogenize the treatment in our group, we could, in a couple of years, maybe a little bit more, we can analyze the results of these guidelines. And then for patients who do not achieve CR or PR, either they are in good general condition and younger than 70 years, and we recommend a second-line chemotherapy with intensive chemotherapy and autologous stem cell chemotherapy, autologous stem cell transplantation, sorry, as a consolidation. For older people or people in a poor general condition, we recommend either a systemic treatment with temozolomide, lenalidomide, ibrutinib, which are off-label for this disease, or a local treatment with irradiation or intravitreal methotrexate. For patients in poor general condition who cannot receive high-dose methotrexate, we recommend either temozolomide as a single agent or a local treatment with either ocular radiotherapy or intravitreal chemotherapy. And then again, the other option for patients in stable, progressive or relapse, local treatment, irradiation if not performed before, or temozolomide, or again, lenalidomide or ibrutinib. We also recommend the assessment, how to assess the response to homogenize the care of these patients. So at baseline, sleep length and fundus angiography and OCT and the level of IL-10 in aqueous are recommended. Before each cycle, if possible, we recommend a slit lamp and fundus examination, or at least, if not possible, after before each cycle of chemotherapy, we recommend it every 2 months, and absolutely at the end of induction, before starting the consolidation treatment. At the end of the induction, also, we like to have the measure of IL-10 in the aqueous and angiography and OCT also. Then these exams are repeated during, after the consolidation, after the end of consolidation, and then every 6 months for 2 years, and then once a year, we recommend the slit lamp and fundus examination. Angiography and OCT and IL-10 are recommended only in case of any doubt of ocular relapse. So as a conclusion and take-home messages, it's a rare disease, but with a severe prognosis because of the CNS relapse. It really the patients need to be within a team of a trained ophthalmologist, cytologist, and the clinician. We will take care, either hematologist of neuro-oncology for the treatment, for all the challenges that we presented for diagnosis, treatment, and follow-up. And we really need a collaborative, probably at least European effort to find out which treatment is the best. I put here some references for those who would be more interested in details. And with Denis, we wrote 2 recent reviews on the subject where you can find the whole references. And for Denis, I thank you for your attention. And we also thank the ERN-EuroBloodNet because they help us to design and conduct this survey on real-life practices for the management of PVRL. Maria-Angela, Maria, and Victoria for their help. Thank you for attention.
Thank you very much to both speakers, Dr. Soussain, Dr. Malaise.
The question I received is, what conditioning regimens are used for autologous stem cell in case of PVRL? Thank you for this answer. I didn't enter in the details, but we usually use the same than for CNS lymphoma, and we prefer the thiotype-based intensive chemotherapy, either with busulfan and cyclophosphamide in younger patients, or thiotype with BCNU for older or unfit patients. If that answers the question.
Okay, maybe for the other question, the question is how specific for PVRL are local ophthalmological findings? Indeed, so first, if we start with the symptoms are definitely not specific as there are just broad vision floaters. And for ophthalmological finding, indeed, if you well know the differences between uveitis and primary VitreoRetina lymphoma, the signs, the ocular findings are quite specific, but it needs to be quite specialist for uveitis because, for example, the precipitate is just close to the cornea, are not exactly the same in case of uveitis or in case of VitreoRetina lymphoma. And that's the same also for the vitritis. The lymphoma cells are not exactly the same as just inflammatory seen in uveitis. And about retinal lesions, indeed, if you use angiography and also OCT, the subretinal deposits, so just located between the retinal pigment and the LPE and the Bruch membrane, is definitely quite specific. So if you know the pathology, you can have a really good sensation, feeling about VitreoRetina lymphoma, but it has to be proved just not only by anterior chamber tap, but by diagnostic vitrectomy, cytology analysis, and also tests as immunohistochemistry or others.
Thank you very much. So for the question of Monique, I cannot see the surname. I'm sorry for calling you by first name. So I think you can unmute and speak if you wish.
Yeah, thank you very much. My name is Monique Minema. I'm a hematologist from Utrecht, the Netherlands. And thank you very much for this very nice lectures. I'm listening on my phone. That's why I can't type a question that easily in the chat. I have a question for both speakers. First of all, about the diagnostics. I was wondering if it was also possible to do a cell-free DNA test for the MYD88 mutation on the puncture that you do in the eye of only the first, I don't know how you call it, I don't remember how you call it anymore, the humus, the features.
Anterior humus.
Yeah, the anterior, yeah, that's the easy one. The anterior part of the eye. Is it because you said you did IL-6, IL-10 measurements, but can you already do some cell-free DNA testing in that part for the most common mutation that you see in this disease?
Denis, you want to answer? Or?
Yes, I can answer. Yeah, it's published. It's possible to identify MYD88 mutation in not only in the vitreous but also in the anterior chamber, in the aqueous humor obtained from anterior chamber tap. Yes, it's possible to.
I'm not sure it's on cell-free. It's probably in the vitreous itself, but I'm not sure it's cell-free. It's cell-free?
Yes.
Sorry.
Okay, great. And my other question was more about the treatment. In the Netherlands, I think we don't use this systemic treatment at first disease presentation that much as done in France. And I was wondering, do you believe that you are actually decreasing the CNS relapse incidence with this first line treatment that I think that most of the patients received? And would also an option be to have a more stringent follow-up regimen, for example, besides the eye examination, also do MRI of the brain after 3 months, or to diagnose a relapse earlier and to have perhaps better treatment options? Or so my question is really, is systemic treatment in your hands actually decreasing the incidence of the CNS relapse in these patients?
I don't know if it really decreased because we didn't conduct a comparative study, but we thought that the median brain-free survival of 73 months was quite good compared to other published studies. That's it's only retrospective studies. The other question was, do we do MRI in the surveillance?
So I thought it, if it's still doubtful, would also be a strict monitoring after the local treatment. So in the eye, only methotrexate or rituxan in the eye would also be a strict monitoring. It of course wouldn't help against the relapse, but could it perhaps also be an option? And did you see in your survey that you did in Europe that there were countries that have a strict follow-up regimen to have an earlier diagnosis of a relapse or brain relapse, CNS relapse in these patients? Yeah,
but then we'll have to define how frequent we'll have to perform the MRI. We usually do for intraocular, for primary vitreoretinal, we usually recommend cerebral MRI once a year. But I think
Okay.
that would be difficult because difficult to recommend every 3 months for many years. When you know that people are refractory to repeat the MRI for CNS lymphoma for the follow-up, you know, some teams would like to reduce the number of MRI. I don't think we can recommend MRI every 3 months for primary vitreoretinal, and the relapse can occur kind of late in the history. And it can be 5 years or 6 years, so it would be very difficult to do an MRI every 3 months for 5 or 6 years.
Okay.
But we do recommend MRI at the beginning, at the diagnosis of primary, because we observe and we know we have cases of patients who present with ophthalmologic signs, but they do have an asymptomatic brain disease. So it's mandatory at diagnosis.
Yeah, to do a full workup.
Yeah.
Okay. Thank you very much.
You're welcome.
Thank you. So we have other 2 questions. I can read them from the chat. How you assess result of IL-10?
Denis?
Yes, my microphone was mute. We have, we do not present the complete information about IL-10, but we assess result by an absolute level of IL-10, but also a ratio between IL-10 and IL-6, and calculated from a mathematical formula from, it's called EASL score for evaluating the prognostic risk of PVRL. And there are specific cutoff not provided here, but they're available in the literature to assess IL-10 level, for pathological IL-10 levels. And IL-10 is quite specific of PVRL, and IL-6 is more specific of inflammatory or infectious disease. So the ratio and the comparison between both IL-10 and IL-6 levels are useful for our diagnostic orientation.
Thank you very much. So we'll go through the other question. Good evening. Thank you for the interesting presentation. Would you recommend performing both anterior chamber tap and vitreous biopsy in the workup for PVRL? In which scenario would you choose one diagnostic procedure rather than the other? Thank you.
Well, good question. In fact, it depends on the clinical presentation and the history of the patient. If you have just at the beginning a doped, you can perform an anterior chamber tap to have a diagnostic orientation. And if, for example, IL-10 is positive and you have a high suspicion, you will then go through to a vitreous biopsy. But if you have at the beginning pure signs of VitreoRetina lymphoma, the dense vitreous, the retinal infiltrate, the diagnostic vitrectomy, you can go directly to vitrectomy. It's not an obligation to perform before an anterior chamber tap. And another problem is if you want to do both in the same time, well, performing a vitrectomy just after anterior chamber tap is difficult because the eye is hypotonic, so it's not easy to combine both. And performing the anterior chamber tap after the vitrectomy is not a good solution because during vitrectomy you will use balanced cell solution, so you will dilute the anterior chamber tap. So performing both in the same time is not a good idea, but sometimes you can, if you have dope, just perform anterior chamber tap and confirm it with vitreous biopsy. And if you are have good sign in favor of PVRL, you can go directly through vitreous biopsy. But also you will use also anterior chamber tap for the follow-up of the patient. But it's difficult if you have performed vitrectomy at the beginning to compare the IL-10 level during follow-up. It's not possible to directly compare them.
Yeah, we put in our recommendation to have a baseline IL-10 level in the anterior chamber to optimize the follow-up also and to better define the response, therapeutic response, which is a problem. So we hope to we would like to assess the role of the IL-10 in the assessment of response, therapeutic response. So we recommend to do it at baseline and then at the different time of after the treatment.
Okay, thank you very much.